Good evening and welcome to this webinar. My name is Sue Larsen and I'll be your facilitator for the evening. It's no secret that the spread of the coronavirus has created major challenges for the Australian government and healthcare system, and many medico-legal experts within the personal injury sector are now wondering what the nature of work looks like for the foreseeable future. Personal injury assessments are considered an essential service, but given the government requirements around social isolation, the safe course of action now is to limit face-to-face interactions unless absolutely necessary, and that means considering assessments conducted via video conferencing. Of course, telehealth has been used in Australia for many years, but its adoption amongst specialists is less than 1%, which means the vast majority of Australian medico-legal experts are now wondering how to quickly transition to telehealth, what strategies others are using to help them make determinations in the absence of a physical examination, and indeed whether an impairment assessment can even feasibly and reliably be undertaken without the physical laying on of hands. All of these questions are extremely valid, and from the outset I'd like to acknowledge the view of the panel and myself is that face-to-face consults are of course the gold standard. But the world has changed over the past 3 weeks, and while it's no doubt there are limitations associated with video conferenced assessments, it's now time to look at what can be done and how it can be done, rather than all the reasons why it can't work. And for a few words on this, I'd like to pass over to Dr. Richard Seckel, Co-Chair of the Education Committee for the Australian Medico-Legal College.
Thanks, Sue. We're highly appreciative that MedDirect has assisted Australian Medico-Legal College to provide this training session on telehealth to our AMLC fellows. Telehealth is used successfully in clinical medicine as the treating doctor presumes that the patient is reliable. In contrast, medico-legal doctors are required to confirm or refute the claimant's claims without bias, no matter who referred the claimant, as our duty, of course, is to assist the court. Some respondent insurers and their solicitors at this stage are unhappy to refer for telehealth medico-legal examinations as there's reduced opportunity to forensically examine the attendee, including, for example, being able to do non-organic validation signs. Telehealth medical examinations can rarely be as fully reliable as a face-to-face examination. Nevertheless, telehealth will probably be with us for at least, I'm guessing, 12 to 18 months until the world is vaccinated against coronavirus, especially for those of us who are in the older age group, which is, of course, the great majority of doctors doing medico-legal work. Therefore, the purpose of today's webinar is to seek the best methods to ensure that medico-legal assessments will continue with adequate reliability. CIRA on Thursday circulated an important update to their approach to COVID-19. This included planned amendments to the workers' compensation guidelines to allow IMEs to be performed by telehealth in special circumstances, and it states that COVID-19 is one such special circumstance. Just tonight, AML circulated to all of us fellows, a 6-page document compiled by our president, Drew Dixon. It's absolutely brilliant. I've got to say, I fortunately was able to read it in a few minutes between arriving and setting up for this evening, and it's an absolutely brilliant document summarising the current recommendations of who and how we can assess for IMEs. It's better than any documents I've read until now. I strongly recommend it to all of us, to all of you, that you read it, and I'm sure that it should be published widely, and it will be, I'm sure. Today's webinar is extremely timely as we all start to grapple with the question of how to conduct a telehealth IME. There's a bit of a feedback coming through. Anyhow, AMLC, we thank very much the panelists for their time, and we look forward to hearing their experience and suggestions. There's no doubt that as a medical specialty, IME consultants must address this issue head on, how to deal with telehealth. And we see tonight's webinar as a starting point for us all to learn and adapt to a new way of working. So tonight is about recognising that this is new for most medico-legal experts, to share their wealth of ideas and to learn from each other. Thanks, Sue.
Thank you, Richard. Okay, so to get started tonight, what I'd like to do is ask you to consider 2 quotes, given that this is new to all of us. The first is this: every adversity brings with it the seed of an equivalent advantage, and the day you plant the seed is not the day that you eat the fruit. So we're really at the seed stage right now, but over the next 6 months, the personal injury sector will become so much stronger in its expertise in delivering video conferenced assessments. And to help plant and water those seeds tonight, I have a wonderful panel of experts and people starting out, given that this is all new to everybody, but who are going to share their experiences and their perspectives on making the transition to telehealth. So I'd like to introduce them to you right now. So introducing Dr. Vid Kasakar, neurosurgeon from New South Wales. Maybe pop your hand up, give us a little wave. I'm sure you're all very well known. Dr. Eugene Gear, orthopaedic surgeon, also from New South Wales. We have Dr. Todd Gotthelf, also New South Wales. We have Miss Karena Nicholls, who is a partner at Coutts Solicitors, and she has more than 15 years experience in all areas of injury compensation and employment law. And finally, we have the Victorian, Dr. Ralph Poppenbeek, representing Victoria, our occupational physician on the panel tonight. So I'd like to welcome you all here tonight and thank you for sharing your views with us. Now, we're going to cover a number of areas tonight, but before I start and provide an overview of what those areas will be, I just wanted to say heads up, give you all a heads up that we've had a very strong response to this webinar tonight, and I think that's a reflection of the amount of interest from all of you college members around how we're going to move forward and what things can be done, where are some of the limitations, and how do we try and mitigate some of those things. So tonight we have incorporated a lot of questions that have come into me prior to the webinar over the last week, and rather than skim over these in an effort to finish the webinar in 1 hour, we have decided to extend the webinar to 1.5 hours so that we can do justice to all the questions that have been submitted prior to tonight. And we'll also be having live questions as well. I'll run through that in just a minute. But what we're going to cover is, firstly, what are the current expectations from the regulators? What are you being told to do, and what accommodations are being made? Secondly, we're going to be looking at setting the consultation up for success. What are some of the broader logistical things that you need to consider to ensure that the consult via video conferencing is as successful as it possibly can and you're getting as strong outcomes as you possibly can? We're going to be looking at how to conduct examinations via video conferencing, and I know that there were so many questions that were submitted about this. I know that it's a very tricky area, and tonight is probably the start of exploring ways to move forward, and that will be a moving feast. It will continue to evolve. This question on everyone's lips: can impairment assessments really be done, and can they be relied upon? So we're going to be discussing that point tonight as well. I'll be addressing some issues around security and different video conferencing platforms. Are there any recommendations out there? Anything that's been mandated? What are some of the things you need to be aware of? And then finally, we're just going to be sharing a couple of initiatives and resources to help you beyond this webinar. So thank you again for all being involved. Because of the number of people who have been registered for tonight, we're unable to have audio on the webinar. There's just too many people, but we really do encourage you to submit your questions. Throughout this webinar, I'll be stopping at different sections. I'll be perusing the questions as they start to come through, and I'll be throwing to some of the different panel members to seek their opinion and perspectives on the questions. So I think it's time to get straight into it, and I'm going to really start to look at now the question around what's expected of medico-legal experts in the current environment. It's important for us all to know if there are any recommendations or guidelines that have been put forward from the regulators, the tribunals and the courts. What are they currently saying? What messages are they giving? So I'd like to start firstly with Vid in New South Wales and ask you, Vid, what messages are being communicated right now by CIRA?
Sira is saying that this is a special condition and we should adapt ourselves to the special needs, and it may not be the perfect, but this is the best that we can do at this stage, and we need to inform the clients that this is what we are doing, and it may not be the best, but till something better comes, we need to accept this as the best option.
Yeah. Great, thank you, Viet. And I think that's really important. This is not going to be a perfect science, and when you leave here tonight after this webinar, it's going to have opened up a number of questions that you hadn't even thought about when you came in. I think very much the message from Sarah is we're moving ahead. This is a special consideration, a scenario that's considered a special consideration, and we would like you, as far as possible, to continue on using video conferencing. Now, Ralph, you are operating in the Victorian arena. I'm just wondering, you've been very busy actually over the last 3 weeks, and work hasn't really stopped for you. Could you please share with us, Ralph, what are the messages that you're receiving in Victoria from BWA and TAC and even Comcare?
Well, I just happen to have the WorkSafe recommendations in front of me, and the requirements are that the IME has the capacity to provide the full service through the telehealth medico, satisfied that it's clinically appropriate, maintains a valid visual and audio link, satisfied that the software and hardware to deliver the consultation meets the applicable laws for security and privacy, and where the medical examination is conducted by telehealth, in the report, you must state that this was done via telehealth, specify the telehealth attendance was audio and visual or audio only, and state what software was used. Now, these are fairly basic sort of things. The statement is that this will continue. This is dated early April, but there's no end in sight, as we all know. But I think I've sort of classified this into different types of consultations. Standard one is for insurers, which is the standard IME examination. That's relatively easy through work cover, TAC, whatever, because it's largely history biased. Questions of diagnosis, work relationship, treatment, work capacity are usually determined by taking a very detailed and thorough history, which is more important when you're doing a telehealth consultation than with a face-to-face one. The ones that I have trouble with are the fitness for duty assessments. Now, that's a particularly difficult assessment to make even if you have face-to-face contact with the patient, because you're asked to make predictive comments regarding whether the person can return back to their normal work safely and continuously and without risk of further aggravation. Now, in order to make those predictive comments, you've got to have all the data possible. Now, you're missing one important part of the data because you can't physically examine the patient. So I really sweat blood in making those kinds of assessments, and I point out all the ramifications of what I'm doing, all the limitations, and this is my best possible estimate of what you're asking. And I think that's all you can do.
I think certainly what you're saying is that, you know, while the guidelines are saying to move forward as much as you can, there will certainly be scenarios where, in your best judgment, it'll be difficult to provide an opinion on that. And we'll certainly be looking at a number of these kinds of things as we look at, you know, what do you think can be done, what can't be done. I guess the message in your sectors and scheme, Ralph, are certainly around, well, we do expect you to keep going, and it's up to you and your judgment whether you feel that you can adequately conduct the assessment. And also the onus being on you to choose a software that meets security regulations or security requirements, and to make sure you're feeling comfortable with that tech so that you can get the most from that assessment. Ralph, we'd love to hear a little bit more about those kinds of assessments that you can do, and we're going to talk about a whole range of different clinical examinations as well a little bit later.
Okay.
So thank you, Ralph. Karena, as well, you know, as a lawyer, from the court's perspective, and also your dealings with Sarah Eye Care, what's the message that you're receiving as a lawyer?
Okay, so basically what we're receiving is that keep on going. I agree with Ralph. Between iCare, the CIRA, Comcare, the Workers' Compensation Commission, one of the comments that was made by Judge Phillips from the Workers' Compensation Commission, who's the president, said that we all need to be creative, we all need to adapt, and that we need to adapt a process that will give and continue to give justice. So what that means is that if we aren't progressing claims and moving them through, then it provides an injustice to the injured worker or person, and that creates an imbalance and also a backlog of claims. And depending upon which scheme you're in will depend on what that means to you, because it all works on generally a statutory entitlements. So after so many weeks, and then you move through the process. So the information that I'm receiving from the commissions and tribunals is to keep on going.
Okay. And that message being that, you know, we have an obligation to keep the claims moving forward and the opinions moving forward as best as we can. Certainly noting, Ralph, that there are going to be scenarios where that can't happen, and that could well be 20%. We don't know yet. It's a whole new ball game, and we're all just working that out right now. But message is keep going where you can. Thank you so much for that. Now, Vid, I'm going to ask you the next question. Followed by Eugene. And over the last few weeks, Vid, you have conducted a number of assessments via video conferencing. And over that time, you've learned firsthand, I guess, about what things do and don't work and how to ensure that you're getting the best possible outcomes from the consultation. So we're talking now about your setup, not so much about the clinical aspects, but when you are preparing to do a video conference assessment, when you're thinking about the location and the environment, and the technology indeed as well, what are some of the things that you've learned can set you up for a better outcome and enable you then to focus on the clinical aspects? Vid.
Right. Thank you. I have done so far about 15 of these assessments. What I have learned from that is that different clients have different access. So I have got Zoom, Skype, and FaceTime all on my computer, because some of them would prefer one to the other, others are not computer savvy. I do all these consultations in my office, as you can see at the back. I have a secretary who arranges all these consultations, and about 10 or 15 minutes before, she contacts the clients either directly from the telephones or email or through the service provider and get them ready. And then depending upon whatever computer system they would like to use, she opens that on my computer, and then I go and sit there and do it. And the more important thing that I've learned is you need at least 10 to 15 minutes sometime to get the system going, because the clients, some of them will say that my telephone is not charged, I'm somewhere else and I don't know where to do it. So sometimes you need to educate them. That takes about 10 minutes. So you need to give time for that. So you can't have 45 minutes clientele one after another as you did. You need to give about 15 minutes between.
Yeah. And I think I saw a few heads nodding on the panelists. I saw Ralph and Todd and Karena as well nodding about those sentiments, that it can take a little bit of time to set these video consults up, and that, you know, to have somebody who can support you in that role beforehand will free you up enormously to focus on the medical aspects of the consult rather than trying to get the tech right. Because as you say, you know, you've used 3 different platforms over the last short while, and you've had to, not only have you had to work it out, but also the examinee has had to work it out. I'm going to be talking a little bit later about tech platforms and some of the pros and cons, you know, a little bit later on. But I think you give a very good message about planning it in advance, and also potentially even, you know, having it get tested with the examinee the day before. If you've got a practice manager, then that's a fantastic resource to use. There are also other resources like Telehealth Tech, which is a telehealth concierge service, and you can get them to do that aspect for you, give them the details and they'll speak to the examinee, check the technology, check that, you know, if you're using Skype, that they've downloaded it. So there are some support services around that can help you with that. Thank you, Vid. And Eugene, you've done at least 20 assessments, I think, now using video conferencing over the last couple of weeks. What advice can you give
anyway, first of all, thanks Richard and Sue and Ross for inviting me onto the panel. I've had an opportunity to do about 25 today, and some of the things I think are important are try to have a support person available. It can be a friend, relative, a child, you know, as long as they're of legal age. I think that's really important because you can conduct this across your computer or even using your phone. And during the course of the examination, you can get them to point the phone at the part of the body you're examining. For example, at the back, if it's rotator cuff muscle wasting, while you're doing the measurements of the shoulder or the knee. So the support person can point it there and also can take a long shot when you're looking, say, at gait. The next thing I think is, I remind them, please take it seriously. It's a medical legal report. I've had some people who want to do it out in the paddock in Lithgow or sitting in their car or sitting in a real estate office, phones going, other people around. So it's an important business. Please take it seriously. Now, one thing, I think it will be a challenge as we go, but we'll work it out as we go and doing various things. Now, measuring angles, goniometer, I found it's pretty easy. You know, the angle you measure via the screen and versus face to face, it's the same angle. Measuring linear measurements, they're a little bit different. There may be magnification, demagnification. If you're a purist, you may want to work that out. I'm not going to go into that here. Now, things like other things that are a challenge, a muscle bulk. Well, you can ask them to have a tape measure handy, just like Vic, and I support what Vic has said. You plan it ahead. I send a message to them about 30 minutes beforehand saying, I'm going to call at 12 o'clock, please have a support person available. And we're using, say, WhatsApp, for example. Well, I've actually used WhatsApp, and everybody seems to be familiar. We have a tape measure available. Now, things like spasm, guarding are hard to assess. I agree with that. Sensation can be a little bit of a challenge. But so far, it seems to be working well. Just remember, we're protecting ourselves, our families, and of course, the clients. And actually, I've found the clients really appreciate that you're prepared to do it this way. Thank you.
For sure. Thank you, Eugene. And I guess I've heard a similar thing as well to what Ed has said, that there's preparation is going to be key to getting some good outcomes here. So if you do need them to be prepared with a tape measure, then you need to let them know in advance. Similarly, if it's a kind of device like a mobile phone or an iPad versus a laptop, then within their scope and knowing that there are limitations there as well. But if they've got some advance notice, or if you would like there to be a support person there, and we'll talk about that later as well, giving them some advance notice so that you can get the best out of the assessment. And Eugene, we're going to come back and look at some of those strategies as well that you've proposed in a moment. I just want to quickly touch on just a couple of, I call them hygiene factors. They may not seem that important, but they can impact the outcome of the assessment, and that's around the setup. Firstly, camera placement and camera usage, that, you know, nobody wants to be looking at the top of your head or up your nose, or, you know, having a camera screen that is being moved all the time. It's very distracting for the other person. So just bear in mind some of those things that maybe you're focusing on the tech and you're not so much focusing on the appearance, but also their appearance as well. Where do you need them to sit? Do you need them to be further back? Just consider some of those things up front. And I know Ralph's going to touch on one of his experiences as well. So is your location likely to be distracting as well? Have you got backlight so that all they can see is your silhouette? So bear in mind some of those little things. What are you wearing? We've all seen TV shows, newsreaders who've got checks on and prints, and it does crazy things with the cameras. Again, it might seem like minutia, but it's all small things that can detract from the person's ability to focus and to move, to give you, you know, a focused response. Considering noise as well, dogs barking, people going past, it's the same, in that we want the examinees to be in a quiet, non-distracting place, that we also need to monitor for that. Again, hygiene factors, I call them, but just is good to have a 5-minute check before you go on to check those kinds of things. And software, testing the software is really a key message, I think, that came as well from VID around test your own, know your own platform. Ralph told us about the Victorian guidelines, which said, it's really your onus. The onus is on you to make sure you know how to use the tech effectively so that you can then do the best with your consult. And, tech can be all of our undoing. We've all been there before. So test, and we'll get your 20-year-old, son or grandkids or whatever to come and practice with you until you feel really confident. So we're going to look at some of those issues a little bit later. But now, Ralph, the next question I'd like to throw to you again, and you have done a lot of these assessments over the last 3 weeks. Why, Ralph, have you elected to do the video conferencing as opposed to face-to-face in the foreseeable future?
Well, it's very obvious to protect myself mainly, but also to protect the patient. The other thing I've found is that when, I think it was late March, I'd have, say, 5 assessments booked on a particular day, none would turn up. And I thought, well, it's really pointless coming in. So it's not working out that way. It's got to be done this way. And also, I had a couple of fitness for duty assessments booked prior to all this occurring. A couple were in Wodonga. Now, obviously, you can't drive there. And so it gets back to what we were saying before about the equipment. One of these was done in a boardroom where the camera was high up on the computer screen on the top of the wall, and the microphone was in the middle of the boardroom table. You had a choice of either watching the person or listening to them. And I had to get the person to move around. And it gets back to the fundamental thing, as well as knowing your equipment, setting up the things that Eugene and Vid have been saying. I think the most important part of all of this is to establish a really good rapport with the patient. You've got to be super nice. I find it's useful to ask them, are they coping with the lockdown? Whether they're having any problems? Are they able to get food? All this kind of thing. And it's very useful because people respond to that and I think, oh, this guy's interested in me. It's always important to do that even in a face-to-face consultation, but it's far more important in this situation because you're asking people to do things so that you can examine them. You're relying entirely on their understanding of what you're saying and their goodwill to go ahead and do that. And you can't do that unless you've got really good rapport. So you've got to be bright, cheerful, keep the ball rolling, and show that you're interested in people far more than you normally would. It's like advice I read once about buying a car. Be nice to everybody. And it's the same thing here. You've got to be nice. Otherwise, it's not going to work. And again, you've got these different types of consultations. One of the ones I did was a worksite visit. Now, that was a real challenge because obviously I couldn't do that. But you find that companies have job descriptions. Now, sometimes they're very thorough. They have photos and they can send you that by email. Sometimes they have little videos showing the jobs. And sometimes you can encourage the factory manager to go around with a video camera and produce a commentary. Commentary is often difficult because factories are noisy places. And then you've got to, again, it gets back to taking a really, really detailed history. You've got to get a good idea from the person of what they actually do. And I think the most important thing here too is to say to the person, look, you know your job far better than I do or anybody else does. Do you think you can do it? And if not, what changes are needed? So again, it gets back to establishing a really good rapport and getting the best out of the consultation. That's my main issue with all of this.
Great. So in transitioning, your message is to absolutely work on the rapport because it isn't a perfect environment. Things are going to go wrong, and the more that you can bring people along with you, the better the outcome is going to be, and the more willing they will be to, do the things that you're asking them to do, so you can examine them appropriately.
Yeah.
Great, thank you, Ralph. I'm going to now go to Eugene, and ask you firstly, how have you found the transition?
Sorry, can you repeat that, Sue?
Yes, how have you found the transition now that you've done probably?
Actually, I found it a lot easier than I expected. I had a chap who'd just gone back from Bali a few days earlier. Then I had another chap who came into the office quite sick, unwell. And so, we've all realized that this is a very serious business. This whole viral thing is really serious. It's a risk for all of us and our clients. So with that in the back of your head, you think, well, this is here. We've got to do it. We've got to adapt to it. So just like Ralph, I think you'd be a bit cheery. I always express my gratitude to the client for being prepared to try. But I've always been amazed, Australians with their attitude, distance, and all that sort of thing, are very happy to do it this way. They really appreciate the effort you're making. So I haven't actually found it as difficult as I thought it would be.
That's good. That's good to hear. And here's a question that's been submitted in the last week, and that is, I'm going to ask you all, Ralph and Vid as well, what impact do you think that this medium has had on your ability to provide an effective report, and in particular, including your ability to address causation and why recovery may not be proceeding in accordance with the natural history of the injury or disease? What impact has video conferencing had on those aspects? Eugene.
Well, I think the only challenge, being an orthopedic surgeon and, doing physical measurements, that's our thing. I just find that trying to refine that and do it as accurately as you possibly can. I see that as a challenge rather than causation, but I'll be interested to what Todd might say about that, being a fellow surgeon.
Well, Todd, I'm going to throw to you then. And let's see, Todd, what your view is on that.
So, as far as assessing someone, just like Eugene says, when you're doing things you can do by history, like causation, I think you can do that from documents, from history, from observation. I think it's doable. I think what's challenging to us is the physical examination part. And while we can do some things, which we may talk about later, in terms of different ways of measuring. It's funny, Eugene mentions the simple goniometer, and we're dealing with digital. I thought we have to use digital, but you're right. We could just use a simple goniometer and stick it on the screen. That would work. But there's other things that are really hard to do, like Vid might know, is obviously numbness. How do you detect numbness or 2-point discrimination? And you really can't ask someone to do that for you. So that's really difficult. So. Yeah. That's a challenge. I think that looking forward, I think nothing's probably not solvable, but it's something we definitely have to work through as we get used to this all.
Correct.
Thank you. So I'm gonna actually throw to Vid now as well, and just ask you, what have you how have you found the transition and your ability to actually address issues around causation? What's your experience been like, Vid?
If you get a good history, you already know what is the probable causation. And that gives you a pretty good idea whether the causation was valid or it was being invalid or it is being put up. And when you examine the patient, you can get a better idea. I usually tell the patient, move the furniture away. I want you to stand against a wall. And I want you to walk up and down, walk on your heels and toes, bend forward, do this. And then I ask them to do their own self-sensory examination. I tell them, look, feel with your hands both sides of your legs, inside, outside, and the thigh. Tell me if there is a difference. Another day, I picked up a guy who had a neuralgia paresthetic on one side. And then there are also people who say the whole of my lower limb is numb, or the whole of my upper limb is numb. The numbness goes to my face and to the forehead, then you can ignore it. So history and clinical examination are more important. Unfortunately, we tend to rely on the radiology. You can only see the radiology, what you already know with your history and clinical examination.
So I think as well, Vid, you said that for your specialty type as a neurosurgeon, you felt that most assessments could probably be done by video conferencing at this early stage. Ralph, yes. I'm gonna throw to you, because I know you've mentioned that fitness for duties are a little bit challenging for you. I'd love to just hear from you. What things do you think as an OC physician can convincingly and reliably be done by video conferencing, and where are some of the hairy areas at this early stage of our progress?
Yeah, sure. When I first started doing this, I found it terribly daunting because, you know, it's a different kind of thing altogether from what you're doing. The patients I found, the same as Eugene, they seem to appreciate you're going to the effort to do all this, and they're generally pretty cooperative. But getting back to the question you asked, I think there are two basic groups of assessments that you do in this situation. One type is predominantly history biased, such things as diagnosis, causation, work capacity, comments on treatment. You can do that without doing a thorough examination. To take what Vid was saying a little further, if the person describes pain down the lateral aspect of the leg, it's L5, the back of the leg, it's S1. These are fairly simplistic sort of things. You can get the stand on the tiptoes, the heels to assess the motor function of the various nerves. You can't do a Tinnell's sign, for instance, but you can do a Phelan's or a reverse Phelan's. You can get them put the hand right up to the screen to see if there's any thenar wasting. You've got to think laterally and try to work out other ways of getting the information you want. But particularly things like causation, if you can get the referrer to send you a lot of information, and this is really the big question in Victoria, they often don't send you radiology reports. And then you ask the patients, and yes, but I sent that all to the insurer, but they don't send it to you. So it's very important for insurers to be educated to do this. Lawyers, I find, on the other hand, send you everything you could possibly ever need in a million years. They're very thorough. But insurers can be a bit of a problem that way, and that can be useful when you're answering questions about causation and so on. Causation, I think, is fairly straightforward because you're doing a predictive evaluation of probability, which, you know, in medicine, we're very familiar with all that. But questions that are predominantly examination biased are really, really difficult in this situation. Again, as we've all talked about today, you do some lateral thinking, you work your way around various things, as Todd and Eugene have talked about with the goniometer, for instance. But there are a lot of things where you've got to be pretty creative, and you really have to think about it. I mean, I think if you've been doing this for a while, you become pretty creative anyway. You got to remember that people with the best of intentions aren't necessarily going to tell you exactly what you want to know. So all those variables can be amplified and become a bigger problem when you're doing these. I'm not quite as daunted as I was at the start, but it still is quite difficult depending on the response of the patient, which is the same thing as any IME that you'd normally do anyhow. So some of those things are amplified and some are easier.
Thanks, Ralph. So you've mentioned some things that you do as an alternative to what you normally would have done in a face-to-face scenario. You've mentioned Phelan's sign versus Tinnell's sign. Are there other things that you are now tending to do to help you determine your opinion in the absence of being, you know, there and physically laying on of hands? Are there any other tips and strategies that you can provide for our participants tonight?
Yep. I think a lot of what we do is based on consistency. So you need to look for consistency between the history, the examination findings, limited examination, radiology, and also find if people have been examined in the last few months by a doctor who's been able to do a face-to-face examination, it's lovely to read their examination findings because it tells you a lot. So you've got to use what you can. But I think it depends on the quality of the questions that people ask, and they can be so difficult sometimes. I like doing the Victorian work cover work because they're standard questions that they cut and paste, and they're definitive things. But employers that send you workers for fitness for duty assessments who aren't really familiar with what they're doing, they'll ask you a question which has got 5 different parts. And then you've got to tease out all those parts and answer the question, because that's your job.
And I think, Ralph, that's a really important part, given that we are in such uncharted territory right now. And you are dealing with case managers who don't understand your space the way that you understand your space, and lawyers and vice versa. I think what we're going to see evolve over the coming 6 months is hopefully more communication to say, look, you sent me this request. I can do this and this, but I don't believe I can do this. So what is the information, the nature of the information that you're really trying to uncover, and I'll get you as far as I can. And whatever I can't do, I will certainly comment on. So hopefully out of this period will become, I guess, a little more communication around, I can't do this, so where do you want me to go from this? Yeah. Eugene, I'd love your thoughts on what are some of the things that you are now doing in the absence of physical laying on of hands that you're now using to help you build your confidence in your opinion.
Yeah, well, I agree with Vic that you can get them to rub their own hand up and down their leg, their shin, and tell you whether they can feel it or not. Otherwise, we used to just rub our hands up and down, and they have to tell us whether they're telling the truth or not or whatever. So you can do that. You can get the support person to do it. You can't do the 2-point centric discrimination. I'm going to have to think about that for a while, or some clever panelists can work that out. The other thing is I get them to tap out their own reflexes, just to tap the front of their knee, just below the kneecap. You'd be surprised they can do it. Or the support person can do it. Obviously, anyone can measure with a tape measure. Everyone's got a tape measure at home, and they can measure the calf circumference, thigh circumference, or if you want to measure biceps, fine. Anyone can do it. But one thing I just do mention is I've found it takes up to 50% longer to do your report. Yes. Well, I guess with a little bit of time and practice and get back what you normally do.
And we've certainly had that question, Eugene, we've certainly had that come up in the questions, that it does take a longer amount of time to conduct these assessments. Probably
for me,
extra.
For me.
Yeah. Look, I think it's a reasonable expectation. I know, Ralph, you mentioned it. Eugene, you've mentioned it. One of our participants has also mentioned it. And I think I guess the new normal for a while is it will take you a little bit more time.
Yeah.
So, Vid, you also mentioned a handful of things that you have been doing, and we'd be keen to hear if there are any other strategies that you could impart on to others. But also, we had a question that was submitted around, well, how do you actually identify if the patient's complaints are genuine or have been exaggerated? So any tips and strategies, Vid, that you have, plus we'd love to hear your response to, how do you sort out, whether the complaint is genuine or not?
You're asking me, or who's asking?
Yes, Vid.
Me, okay. Look, I think it is not very difficult, because if the patient's symptoms are reliable, he would indicate reduced sensations over the dermatomal pattern. He does not know the dermatome, but he will tell you the areas. But if the patient says, I got pain in the shoulder and it spreads to my right arm and all my fingers are affected, it's not correct. And sometimes they say, the pain goes up the neck, one side of my face, and on the forehead on the same side. These are not neurological diagnoses. You very well know that this is what is happening. And sometimes I had a guy today when I said, I'll make him lie down on the couch and said, please lift the one leg without bending the knee and lift the other. He said, I just can't do that. He was moving around quite freely. Then he got out of the couch and they said, sit down there, lift the leg up now. Oh, that is not a problem, doctor, lift it up. And then he crouched on the floor on his knees. He said, this is the most comfortable position for me. You can't have a scientific stretch when you're sitting on the couch position on the floor. He said, I can sit like this for half an hour, but I can't get up and drive a car, And then the neck problem. I usually tell if it's a woman, Can you fix your bra straps? Can you wash your hair? These are the standard reductions of movements of the shoulder. If they are present, the chances are that the patient does not have a neurological problem in the neck. So there are various tricks you can use to make sure that we get the correct information. This is standard neurological examination. We all do the tricks.
So maybe it's about thinking on your feet a little bit more, given that you're not in the same room, and thinking about, how do I double guess this? How do I double check it? Thank you, Vid.
Sure.
So Todd, I've got a question that's come in from one of our audience members, and then I'm going to ask you another little curly question. So this is a question that says, Todd, how do you visualize x-rays which are print and not digitally recorded? Do you have any strategies around that? And I might also throw to you, Ralph, because I know you've got a view there too.
It's a good one, because normally we'd have a view box, right? And we can view them. So it's quite difficult if we have the patient have the x-rays there and having to show us. Now, I mean, these days, a lot of people bring in CDs and they don't bring in printed. And so this is a kind of roundabout way to answer the question, but I've signed up with all the radiology departments in Sydney and elsewhere that allows me online access to images, so I can look at the images online. Can you hear me? Sometimes it's good and to my advantage. I had this one client who had a neck problem, and they said, I never had problems before, and I accessed his images online, and I saw that he had neck CTs and MRIs like way before the injury, like multiple times. So I caught him out on that. But you know, it's really helpful to get digital access, and that's something you have to work on to get access to all of them. I'm not sure, Eugene might be better to answer. I'm about to do some telehealth examinations coming up, but looking at printed ones, I guess you can ask someone to put it up against the light. If they have one in their room, they can put a lamp behind the x-ray if you want to do something like that. But it would probably take twice as long, I would imagine, or more.
I agree, Todd. I mean, maybe go back 20 or 30 years when you only had the window or light to look at it. But you know, of course, those links are generally available now, and I think they're useful. And of course, they do have the official report. They can put that up against the screen.
That's right.
It's very easy to read it. It's very easy to read it. But the links are good.
I guess, you know, you have to work your way around these things. And even with technology and face-to-face, we have to work around it too, because we don't have CD players anymore. So we have to do what we can.
And I think as well, one of the things that Vid said to me when we were talking about this upcoming webinar during the week is he mentioned to me about, you know, sometimes you can't actually complete your report, and you've got to ask them to drop the x-rays in, or you've got to ask them to send it in at some stage, and you can complete your report later. Vid, would you like to elaborate on that?
Well, the problem is that the insurers do not understand that we need to look at the hard copies of the x-rays. They tell the client, oh, we have sent all the documents to the doctor, he will know. They meant the reports. I can't make out everything from a report. So as you said, as Todd said, if there is a printed MRI, I ask them to hold it against the camera, and very often I can make out. If it is an MRI film, sometimes I can ask them to hold it against a window. Most rooms that examine have a window. I can have some idea. But if I find that it is not helping me, I tell them to post the films to me. I've got a post box. My secretary goes and picks up the x-rays, and I can look at it. I also got a CD player and look at it. And then I tell them, look, I'm going to look at your x-rays and then complete my report further after I've seen the x-rays. They are very satisfied. There's a doctor, that is very good. I thought you would only rely on the x-ray pictures. No. So it is, you can work around it. Once you get their confidence and say that you're trying hard to find out what is going on with them, they are cooperative. I don't see any problem with that.
Thank you, Vid. Thanks, Vid. So, Todd, back to you. We've had a question submitted about how to conduct a valid and comprehensive knee or foot examination through a video consultation. So, as an ortho, this is your area of expertise. What are some practical suggestions that you could provide for us to when doing this kind of assessment via video conferencing?
I mean, so if we're going to assess for lower extremity impairment, I mean, we also need to realize there's rules behind that, so we have to follow those. And the rules say that we have to look at all different methods and choose the one that's most appropriate and choose the one that gives the best impairment. So, I mean, if you go through them, first is limb length discrepancy. So I guess, like Eugene said, they either had a tape measure, or one of the things that I've played around with was a digital measurement device. There's an app I've used called Pixel Stick, which puts it basically measures pixels on the screen. So you can use that, and you can also convert that length to a distance. So let's say if you know the patient's height and they stand, let's say, back here. Can you see me? Perhaps you need to see the whole body, but you can see the whole body. You can measure the distance, and then you know their height. Then if they stand at that same distance, you can maybe measure other parts. And I think it's crude at the moment, but I think it might lead to some future where perhaps we don't go to the office, but the client does, and perhaps our room is set up with certain standard things so that we can use, like criminals have the little height thing behind them and they stand against the wall and then we see how tall they are. So we can measure distance. Certain things like muscle atrophy, that's a bit difficult, but perhaps you can measure in two views, first an AP first and then a lateral, measure the distance of the leg from the width, and then add them up in 2 dimensions, and maybe you can compare it to the other side, and just that way showing evidence that we have checked something in a logical way and there's a difference. We've talked about range of motion with goniometers, either using the hand one or doing digital. And sometimes you can even, if you get consent, take snapshots. So if you check my arm flexion, we take the angle, we know the angle, and we have proof to show that we've checked the angle. There are things like joint ankylosis, that's pretty easy. Arthritis, we do by x-ray. Amputation, that's not hard. Diagnosis-based estimates, that's all easy to do. The things about that Vid brought up about sensation make sense, and so those things all make sense. I guess strength is a little bit hard, but these things are rare to use. So if you go down the list, we can pretty much do mostly everything, even just now talking about it in the primitive way, that if we work on it harder, I think we can find solutions in the future. That's what this conference is good for.
Yeah, and I think that's the point. I mean, it is such early days, and while we all acknowledge that it's not a perfect or exact science, but it's about looking at now, well, what are some things that you can do, and also, where can you apply this and where can't you apply it? It may be more difficult in an impairment assessment, but if it's around causation or ongoing treatment or other kinds of expert medical opinion, you can most probably provide adequate kinds of feedback for a case manager, for example, to provide enough to go on to make some determinations. Eugene, did you want to add anything to Todd's strategies around how you could I'm just going to turn you on, around how you could
just work it out as we go, refine techniques, and who knows what we're going to come up with. But I think, we just work at it and we're able to work it out. And certain things like muscle atrophy are a challenge, but again, you've got the tape measure. And, range of motion, as Todd said, is used for a lot of the determinations of impairment, because you've got to give them the highest rate, and it tends to work out to be the one that gives them the highest impairment. So if you measure range of motion, it's a long way there to giving them an impairment.
Okay, great. So obviously the main question on people's lips coming into this webinar is around the ability to reliably make impairment assessments via video conferencing. So this next question is firstly directed to Ralph and Eugene, and then I'd love to get Karina's perspective on this from a legal perspective. And I also weave into this a comment around, how is telehealth or teleassessments going to stack up against an opposing IME several weeks down the track that is the opposing view is done via face-to-face? How is it all going to work out? Do we actually think that insurer will pay large sums of money for whole person impairments when currently it's being done via telehealth and then later it could be done via face-to-face? My question therefore, Ralph and then Eugene, how do you deal with the issue of an examination for impairment assessments which are so dependent on a physical kind of assessment and a physical presence there? Is it possible in your perspective to reliably do an impairment assessment via video conferencing? Ralph, we would love to hear your thoughts on this.
Well, firstly, if you're using the DRE, the diagnosis related estimate, doing a impairment assessment via video link is very easy. It only becomes difficult if you have to measure ranges of movement, test muscle power, loss of sensation, all that kind of stuff. You can't do that, in my opinion, very accurately. You can use the goniometry techniques that Todd's been referring to and Eugene's referring to, and I think that's probably the best approximation under the circumstances, but it still doesn't equate to doing a physical examination. So you have to state that this is your best estimate of impairment under the circumstances of within the limitations of your examination. Now, if the person's then examined again a couple of months later when we're all moving around freely, you might be surprised and find that the impairment so assessed is similar to what you've done already. Yeah. And it's an interesting topic for doing a paper on, to compare these things, which I think would be very interesting. I don't think there'd be that much variation between doing a telehealth impairment assessment and doing a physical assessment if you do the telehealth carefully and methodically. I'd be interested in Eugene and Todd's view on that.
Yeah, Ralph, I agree. I agree with you totally. I bet a later face-to-face exam is not going to be that much different if you very carefully do your video assessment. I think there's some things like spasm and guarding may be hard to determine. Sensation, Vic's worked out a system for us there. And basically get the client to come close to the screen for doing the measurements of angles. Stand close to the screen. So these things are, I think they're doable, but we have to refine it a little bit. That's my opinion.
Todd, what's your view? And then Pete, I'm going to ask you as well. Todd, what's your views?
Our duty is to the court, and it's like Karina says, I guess the courts have to get comfortable with this as precedent. And once it does, I think Ralph's correct. Like, if they find these things are accurate, then it will maybe change how we do things. I mean, I think it's going to change how we do things in lots of ways in different industries, how we all are getting used to our lives right now. For instance, I mean, I had a patient call and they had a problem with their leg, and instead of just calling them, I put them on my CoView video conference so they can show me their leg, and it was a post-operative patient just to see what they were talking about, and I had a little mini telehealth instead of a phone call. So it worked out well, and I think I'm going to use that a lot more in the future because I'm getting used to it, more comfortable with it.
Yeah, and I think that's a big fact that Todd, you've mentioned, Ralph, you've mentioned, Eugene, you've mentioned. The more you do this, the more you get comfortable with the medium. You start to think more laterally about, okay, it's not as daunting as I thought. There are ways that I can do this. And I think, even that as a take home from tonight is a great outcome. Vid, I'd like to ask you your thoughts on, can impairment assessments be done via video conferencing?
I think it is quite easy, because impairment assessment gives a broad range of movements and a range of inability. If a person has had a spinal fusion, DRE4 is 20, and then you have added this activities of daily life. And then when it comes to neurological findings for the DRE modifiers, you have various ways: reduced sensation, reduce straight leg raising and wasting, and if they've got problem with their foot, I usually ask them to walk on their heels. If the person can walk on the heels, L4-5 is normal. If they walk on their toes, L5-S1 is normal. So they, however much they say that we are having problem, we can make it out. If they have problem, and if the patient says that I trip when I walk, you can say that he has got a foot weakness, so you give him a little extra. So I don't think assessment, DRE assessment, to me, is going to be a big problem, because there is a wide range and you can speculate. And you can always say that this is the best we can do under these circumstances. If there is a dispute, we can resolve it. There is not much difference between, Karena will say, between 24% and 25%. They're all in the same bracket. I don't think one needs to be so obsessive about the actual figure unless you are very anxious to jack it up for the plaintiff reports.
Okay, thanks, Vid. So, Karena, there's always lots of questions for you from a legal perspective, given we're in such new territory. We had one that was raised in the questions that I pre-briefed a little earlier around, you know, what happens if you do a whole person impairment assessment now by video conferencing, and then later it's done by face-to-face. We've had a question submitted earlier about from a webinar participant who was asked by a lawyer client whether assessing individuals via teleconference could potentially compromise the reliability of the assessment and make it more likely to be open to dispute. And, you know, a lot of questions around this. From a legal perspective, what's your view?
Okay, so I think what we need to realise is that even before we went to the situation that we're in, there's always been a dispute. There will continue to be a dispute, and the only reason that I'm in litigation with the insurers is because there is a dispute. So the reports that we get, some not too far apart, they normally resolve. And now that we have the workers' compensation arbitrator with powers to look at the medical examinations in that light, the Workers' Compensation Commission in particular in New South Wales has moved to the point where we will have a teleconference and the dispute will be raised at that point. And if the arbitrator can actually decide it at that point, then they will. If they feel that they can't, then they may refer it off themselves for a video AMS. So we're still moving into the telehealth video AMS. And then from there, if we can't do it for whatever reasons, and I appreciate each and every one of the panelists saying that in some situations, it's just not doable. And I don't think you should put yourself in a position where you should be doing reports that you don't stand behind, because you all know that medico-legal reports can end up in tribunals and courts, and we need you to be able to stand behind your opinion. So from my point of view, I've always said that we are on an even playing field when it comes to having the reports done via telehealth or any other platforms. I suppose my opinion is that I'm in the same boat as and I'm a plaintiff solicitor primarily, as the insurer. So the insurer will have my report first generally, and then I will see their report. So we can bounce off and get supplementary reports if there's something that's been assessed differently, and that may be the case. But I think, as you said, Sue, we need to look at communication. So really talking to each of the medico-legal doctors and having a conversation about what it is that you need to make sure that you can fulfill the assessment the best way that you can.
And I know you've spoken previously about this discussion, and you know, if a doctor feels that they can't answer the question, that you would welcome a call to say, listen, it's just not possible, and say, okay, well, I still have a case that I need to manage. What are you able to determine given the new medium? So to really open the dialogue up and to talk about what is possible in a clinical setting.
Yes, I've always had an open door policy in respect of that. I think it's really important that as a experienced personal injury solicitor, I'm able to have those conversations with those doctors and say, look, I don't really understand what you're saying, or the language that you're speaking is fantastically scientific, but doesn't help me in terms of what I need from a legal perspective.
From an insurer perspective as well, I know I have had conversations with some of the Victorian regulators. They're taking a very similar view of this to say, okay, we don't understand necessarily what you are now able or unable to do, and we encourage you, doctor, if there's something you really feel you can't do, to speak to us and have a conversation. We'll work out, you know, where is the ground that you can confidently comment on, and to make comment about the things that you can't. Karena, this question we've touched on a little bit, and, you know, how long is a piece of string, I guess, but do you think that over the passage of time, video assessments will be more likely to be challenged?
Okay, so I think, as I said before, we've always had the challenges, so it's not a new concept. So I think if we look at it like, well, now that I'm doing telehealth, my report's going to be challenged. Well, if you're reporting in a matter that's in dispute, then it's going to be challenged in any event. I think that as we move forward, we will see some challenges, different professions, sort of different specialties doing it differently. Not to say that they're doing it wrong, but just that they're approaching it in a different way. So Todd might use an app or some kind of measuring device, whereas Eugene might decide to just use whatever it is that he normally uses. And there might be some discrepancies in that. But I think as we go forward, we'll start to see that there's more of a system in place, and what works for you or what you discuss with your colleagues, which I encourage, you should be looking at, okay, well, does that work, or how did they actually get to that assessment? And maybe I could incorporate that into the way I do things as well, which will give us a more sort of streamlined assessment, because like Todd said, the obligation is to the court or the tribunal, and I think we need to move away from this, well, it's a plaintiff doctor or a respondent doctor. I think we just need to look at it that you're giving us a medical opinion based on the evidence.
Okay, thanks, Karena. I know you're always open to fielding legal questions as well, particularly given we're in such a time of change. So thank you for that. We're going to move on now, and I'm going to refer, oh no, I'm not going to do that just yet. I'm going to pose another question that has been submitted by an AMLC member, and this is to go to Eugene and Todd, and then again Karena as well. And that question is, Eugene, what is your view on a third untrained person being instructed to perform various tests in your absence or in your physical absence? What are your views, and what instances do you think this could be useful?
You know, it's not magical to have a third person there doing the exam, but who is this third person? They're incurring the same risk that you are of an infection from this virus. Or are they going to have to be, you know, lots of PPE and have themselves properly protected? So it's sort of a little bit self-defeating in a way, isn't it? I mean, is this other person expendable? Or maybe...
I think the scenario is if it's a family member who might be under the same roof. So the context of you're at home, they're at home with their wife, husband, or...
Family member falls under the category we'll discuss tonight as the support person. So they're already a member of the family. There's been an exposure to the virus, and you know, they've decided within the family what precautions they're going to take. I mean, you know, we know doctors have had to divide their families, live on different floors, different part of the houses because of their occupational exposure. So, you know, that's that situation. But in general, the support person, member of the family, I think they can, if they're adult, and reasonably sensible can do a lot, can do some of the measurements for you. That's my opinion.
Great. So Todd, do you also think that there could be potentially I don't know if proxy is the right word, but somebody who can help you carry out some of the examination?
Yes.
I think it depends. Like if we do a face-to-face, sometimes we have a family member there. We have to get our interview and history from the client themselves. So we don't want to have another person coaching or influencing anything. And if that happens in a face-to-face, we would have that person leave. So I think that they certainly can help if we think they're reliable and we can use them and we can say they're present in the room. And if they are, just like Karena said, if it's just like a face-to-face, if we think they're helpful, then certainly they can do things that we think they're reliable and we can get the results we need. But on the other hand, if we think they're there and they're influencing, then we would have to make sure that they're not there in the same room, or they have to leave, just like we would in a face-to-face.
Thanks, Todd. Karena, do you see any issues with this from a legal perspective?
So I think we need to just go back to, as what Todd said, we have always sort of encouraged that someone take a support person with them to consultations. A lot of clients find it very daunting and actually creates a lot of anxiety and stress. So from that point of view, that support person is told from our side, and I'm sure the doctors do the same thing, that they're not there to answer any questions, they're only there for support. If we look at it from a telehealth sort of video conferencing point of view, as long as they're not answering the questions or coaching, as Todd said, or interfering with the process, and maybe they're just holding the tape measure, or maybe they're just moving the camera so that the person can stand still, so that the doctors can each visually note what they need to in order to carry out the assessment. And that we put it in the report that we had such and such assisting by holding the tape measure, and that you visually saw them and you saw the number, whatever that may be, and that's the basis or the evidence of your report. I don't see an issue with it.
Great, thank you, Karena. Okay, so now I'm just going to ask a question now for Richard, and that question is around, so I'm just going to get him back on the line. Thank you, Richard. Nice to see you again. So this is, again, looking a little bit around logistics, and then we're going to move on to looking at the tech issues. And we've still had a lot of medical, clinical assessment kind of questions, and we'll circle back to that if we have time to do so. If not, we will answer your responses over the coming days. Now, the question, Richard, has partly been covered, but it kind of, we need to extend it a little bit more as well, and that is, how do you assess or deal with possible third parties, potentially a solicitor or someone else, being covert and advising at the claimant's end of the consultation? But this also leads the conversation on to looking at the issue of consent forms, and does the personal injury sector or the medico-legal does the college need to look at what should now be included in consent forms, given that it's such a new landscape? Should you be looking at them? What should be included? Oh, sorry. My apologies, Richard. I've unmuted you. Oh, now I'll need you to unmute yourself now. Thanks, Richard. You're back on the air.
Yes, back on the air. So, yes, the concept of consent form, most doctors anyhow have always used a consent form, even though it's implicit in the system that if it's, the person's coming to you and has been referred and you've signed a claim form some months or years ago, it's there. Nevertheless, we want a consent form to cover ourselves just in case of a complaint. But this is a very different situation when we don't set eyes on the person. And so the consent form now, and we're just working this through, the consent form will be necessary for a whole host of other reasons in addition to the implicit one that we were saying. For example, it has to be completed before the event, not at the moment of the event or not 5 minutes before, and has to be sent back beforehand. because it will be an explanation two ways, an explanation to the claimant and information back to us. The explanation, and it should involve issues such as who will be in the room, because normally when somebody brings a support person, most of us are perfectly happy to have somebody there as a support, and as somebody said before, not to give any opinion or advice or input or prompting, etc. Just there for emotional support. But of course, when it's on video, we have no idea who's in the room unless we can see them. So one of the items that we're suggesting should go on a consent form signed and sent back to us beforehand is the name of any person who would be in the room. It should preferably only be one person, I suppose, and that person has to be in the view of the video or at all times, so that we can feel comfortable that the person is not prompting and manipulating the process in any way, and also that person can often help with measurements of various things, as people have said. So the name of the person, and that person has to be at all times in the room. Somebody had asked, what if the person wants to have their own solicitor in the room? Well, that's not something that we would normally accept in our own clinics, because the purpose of a solicitor would normally be to give advice or etc. That's not a support person. So we, in the same way as if a solicitor wished to be in the room in our own clinic rooms, we wouldn't proceed under those circumstances. So we would not accept it under those circumstances. So therefore, the name and the relationship of that person who's in the room. What other things to go on this on the consent form? Permission to obtain X-ray reports if they're not available. That would be helpful. I think that's a very important issue, because we often won't be able to access them easily if they haven't been sent to the documents. And I think that probably covers most of what we would say. There will be other items. In an earlier discussion I was having, we thought of 2 or 3 other items, and in following this webinar, we will produce a document of suggestions that came out of this webinar, and it will include that. I think Todd has remembered another item that we had discussed before that should go on the consent form. So perhaps, Todd, you can add to that.
I think we were talking about, special circumstances of things like if we were going to take screenshots of images to show evidence of range of motion or things like that. We should get permission that we can take photos for that purpose. And the other one was, because it's on a video, I think both parties can record, but that's illegal, as we talked about. So we should make sure they have a statement saying they will not record, or we will not record this without permission. Things like that.
You're quite right. The consent form, I believe, and this is early times thinking through, that we should make a statement that the video will not be recorded by us, and it should be signed, as you just said anyhow, that it should be signed by the claimant also, that the video will not be recorded in any way, or by sound or film or video.
Okay, thank you for that. And I think what this does is that it starts the conversation. Tonight is a real conversation starter, and no doubt from this there'll be many more to come, and many more questions about how to move forward. Ralph, I have a very super quick question for you, and I'm looking at the time, but I know that this is a question that has been submitted by one of the AMLC members, so I really want to give it some airtime to answer the question. Now, the question is, Ralph, in review situations where there's more than one assessor, how do we communicate between us during the consultation when the assessors are at different sites? Or do the assessors potentially need to consult from the same single site at the same time?
Could I make a comment first on what we've been talking about with regard to examinations in these situations? I think you've got to look at these the way you would a medical journal article. There's examination bias, and the degree of examination bias the doctor and the referrer are able to accept is really what we're talking about. If they're similar, then there's not a problem, and I think that's where the DRE situation occurs. But I think we're really talking about examination bias. Okay, I've had my say on that. Now I'll answer your question. Well, I've sat on panels where you know, 2 or 3 of us have been in the room together and examined the patient together, or we've examined the patient separately. This is prior to the COVID-19 thing. And then one person is elected to write the report. Now, I think there's not really that much difference here, except that we've probably got to do it with an individual doctor and an individual patient repeated with the members of the panel. That's probably not really inconvenient for the patient because it's all been done in his or her living room or whatever. So they don't have to go anywhere to do this, but it's a bit boring for them to repeat the facts. And then the doctors can communicate by telephone or video conference or whatever, and agree on a assessment. So I don't see a big problem with that using telehealth protocols. The alternative is for the doctors to do what we're doing tonight, of having 2 or 3 doctors together doing the examination of the patient. But I think that's got problems because, as we can see from our answers to the various questions tonight, we've all got different approaches to the examination part of it. Pretty similar history, I think. And if that becomes a type of conflict, and doctors are very good at conflict, as we all know, if that becomes a conflict with the patient in the loop, that's going to create a lot of unnecessary stress and anxiety for the patient. I think it's better in these circumstances for each member of the panel to examine, well, within the confines of this process, and take a history individually, and then confer collectively, and then one person is elected to write the report, which is what we've already done.
Richard, do you have any further comments on that? Thank you, Ralph.
No, I think Ralph covered that fully. No, I think
great. Okay, so we're going to change gears a little bit. I know that we've talked a lot about how to do the consultations, how to set yourself up for success, and knowing that there are many participants on here tonight that haven't done telehealth or have done very few. I wanted to touch base on some of the aspects around what platform to use, and I will refer you to the MedDirect website. We've got quite a lot of detail on different platforms that are out there, and a comparison site between what the different tech does and what the functionality is and how it works and all the costings on, and that kind of thing from an independent source. But tonight, just in a nutshell, I just wanted to, you know, such a large and prickly subject this one, because obviously telehealth is considered a health service where health information is collected and stored. So in the same way that the medical documentation must meet Australian Privacy Act requirements, so too do the telehealth assessments. And as Ralph mentioned earlier, in the Victorian scheme, there was comment around the onus is on you to make sure you're using a platform that meets security requirements. Now, that's a challenge because you got to be pretty tech savvy to know what those requirements are, and indeed to find out what meets the requirements and which platforms currently you are able to use. And I do think this is the challenge. I think video conferencing platforms are a little bit tough to try and work out, well, what is the security requirement? Generally, they're saying that you need to be using a video conference platform, firstly, that has secure end-to-end encryption. That's what security means. But I will also say that on the other hand, you've got, I believe, sites like Medicare and many of the college sites are saying, look, you know, Skype is okay, Zoom is okay, GoToMeeting's okay, WhatsApp is okay, you know, whatever platform that you choose to use, as long as it meets security requirements, is okay. Now, there's a big challenge around that, because some of you who have been following the media will have seen Zoom has gotten itself into a lot of trouble over the last 2 weeks or so, because it has been found to not really meet the privacy requirements whatsoever. However, we're still being given guidelines that, you know, Zoom is okay to use. So I guess my point is here, we're in a very early stage. I think it would be fantastic to get a much more definitive answer about what platforms are okay and which ones not. I can clearly say right now, there is no platform that any regulators have mandated or recommended. The onus has been to make sure that it's secure. But the mandate's also been, as Ralph read out earlier, that it's a technology platform that you feel comfortable to use and that frees you up to facilitate a trustworthy consultation. And I think that's some other issues to consider. You know, which one are you going to choose? Because it has to be simple. And, you know, Greg Cameron, Dr. Greg Cameron has been, one of our partners, and he's been using video conferencing for some time. And he says, you know, the golden rule is keep it simple, because you just don't know what the position is going to be of the examinee. Can they speak English? Are they tech savvy? What equipment do they have? Do they understand how to download an app? Do they understand how to click on a link? So whatever you do use is about being as simple as possible, but it's also about flexibility. Many of our panelists tonight have already said, I've used 3, I've used WhatsApp, I've used Zoom, I've used Skype, you know, CoView, the whole gamut of them. And I think that's another key consideration, is flexibility, because it's not just about what you use, but it's also what the examinee has access to. So in a minute, I'm just going to give you a very quick snapshot of the 2 different kinds of teleconferencing platforms that are available. So one is a download platform, which is Skype. Now, when I say it's a download platform, what I mean, and many of you will be used to using Skype, it's been around for a very long time, but what I mean is that you have to download Skype onto your computer, and so does the examinee. And I know a lot of the colleges, like the RACGP, has been saying Skype is a good place to start because a lot of people are familiar with it, but you do need to consider there is this download component to it that can add a level of complexity to some examinees. On the other hand, you have got what's known as cloud-based software like Zoom, GoToMeeting, like Join Me, like CoView. And so those are ones where you simply log in online, you generate a link, and that link is sent to the examinee. And it's quite simple. At the appointed time, they click on the link, the browser opens up. I know for sure CoView is a secure platform, and some of the others, I just say do your own due diligence on the security and whether it meets requirements. But it opens up the browser, you do the consult, you finish it, you close it, and the record of the link has gone. Unlike Skype, where the examinee now has your Skype address and you have theirs. And I know that there are some doctors who say, oh, I'm not too comfortable about that. I don't really want to be receiving messages on my Skype account or even phone calls. Certainly, on the other hand, I know many practices have set up practice accounts in their Skype name, so they're not too worried about that. Again, I'm just sharing with you some of the pros and cons. Same thing goes for WhatsApp. I know a number of the doctors have mentioned tonight that they've used WhatsApp. WhatsApp is only phone-based, not laptop-based, and you do then need to give your mobile phone. So that, again, is another consideration. So I'm just putting before you a number of considerations to think about when you're considering what platform to use. I think the take-home measure or the take-home message to you is do a little bit of research. Like I said, we've got great resources on the website. Look for secure encrypted is really the benchmark. Look for something that's simple, and look for several platforms, because it's highly likely that you're going to need to use several platforms. Please feel free as well to ask questions about this. I know I've covered it very, very quickly. Now, the other thing I just wanted to mention before we wrap up, it's been talked about a couple of times about, you know, it's early days. We've had a lot of questions. We've had a lot of, you know, what would we do in this situation? And I can tell you we haven't even covered probably half our questions already tonight. So there's a lot further that this can go. And there's been discussions offline as well around, you know, do we keep the conversation going, given that it's really at its infancy? So I wanted to ask you tonight whether you would be interested in being part of an ongoing forum to discuss video conferencing, techniques for doing assessments, tech platforms, etc. And if you would like to be part of that, how often you would like that to be held. Now, I'm going to launch a poll right now just to get your feedback on whether you would be interested in doing something like that. And I'd love you just very quickly to put a yes or no in there, just to give us a sense of whether you'd like us to continue the conversation. We're up to about 50% voting. About 70% have voted. So if the last few could quickly pop their responses in. All right, we're going to close the poll now. We've got about 80% who have voted, and I'll launch the response there. So we have 84% who've said yes, they would like to continue the conversation in some kind of forum. So let me just ask the next question then, and that is, how often would you like to meet? What would suit, if you said yes, I'd like to continue the conversation, what would be a suitable time? Fortnightly, monthly, 6 weekly. Okay, again, we're at about 80% who have voted now. I'm going to close the poll. So any last minute responses? All right, I'll close the poll, and the response to that question was, yeah, monthly or 6 weekly is what would tend to suit you most. All right, so we're now going to take that back to the college, and we'll provide some further information for you a little bit later about what that will look like, and whether that would be set up under specialty group and so on. Now we're going to leave in just a moment. I just wanted to draw your attention to some resources that are available. We're often asked, do you have an information guide that I can print out and give to examinees to help them prepare? This is a guide that again is on the MedDirect website. It's there as a Word doc, so you can put your own logo and your own colours on there. And I will say, we didn't write this. We actually, it's a resource that was on the RACGP website, and it's just been modified for the medico-legal environment. Now, I just wanted to say a personal word of thanks to our panellists tonight who have freely shared their expertise and their insights. It takes a bit of courage and a lot of energy to openly put your perspectives out there for scrutiny. And I'd like to thank the panellists tonight who have given up their time freely. And I'd like to thank you also for giving us the opportunity to run the webinar tonight. So I'll hand over now to Richard to close up.
So thanks, Sue. On behalf of the AMLC, I'd like to thank the panellists for their insightful feedback. As we all consider how best to navigate through this new landscape, I'd also like to thank you, Sue, and the MedDirect team for your openness to provide and freely share the resources with our college fellows, and also for your, Sue's, development and facilitation for tonight's webinar. It's just been wonderful. This webinar has been recorded and will be made available on the AMLC website. MedDirect has advised that their website has a series of resources to help medico-legal experts transition to telehealth, including 24 quick video tutorials covering logistics. I've seen them. They're very short, 40, 50, 60 seconds each, on topics such as privacy, video conferencing platforms, consent, and published papers reviewing the quality of outcomes achieved through video conference consultations. I presume that's very early times. MedDirect has kindly permitted AMLC to send you this link soon to be able to access all of this. So MedDirect has advised AMLC that they're not a medico-legal provider, but a new innovation in the medico-legal sector, having built a practice management system specifically for medico-legal work, enabling medico-legal doctors to work securely, efficiently and directly with their referrers. Sue and her partners have also kindly offered to answer any further questions regarding your own transition to telehealth, and to support you in any way. They advise that you can find their contact details on the MedDirect site. And finally, thank you, college fellows, all of you, for your attendance tonight. It's been a long evening, but I think it's been absolutely wonderful. We recognise that this will no doubt be the first of many steps that our IME will take in adapting to this new and challenging environment. So thank you, everybody. Thank you, panelists, and thank you, audience.
Thank you.
Right.
Thank you.
Thank you very much.
Thank you.
Thank you. Thank you.
Thank you.
Thank you.
Thank you.